Welcome to the National Hypertension Control Roundtable Fireside Chat discussion. I'm incredibly delighted to be joined by our esteemed colleagues to talk about a very important topic, which is uncontrolled hypertension and the impact it has on dementia. Today, I am so excited that our very own steering committee member, Matthew Baumgart, who is the Vice President for Health Policy at the Alzheimer's Association, will be moderating this discussion. So I will pass it over to you, Matthew, to introduce our speakers and lead the conversation.
Thank you very much, Jenny, and hello, everybody. It's an honor to be with you today and to moderate this very important discussion on the link between hypertension and brain health. The Alzheimer's Association joined the National Hypertension Control Roundtable, and we're honored to be a member of the steering committee precisely because of the growing evidence of the link between hypertension and risk for cognitive decline and dementia. So I think we've got a great panel today, and let me introduce our speakers, and then we'll get right into it. So first of all, I'd like to introduce Dr. Richard Benson. He's the director of the Office of Global Health and Health Disparities at the National Institute of Neurological Disorders and Stroke, and that's a big mouthful. Most of us just say NINDS. He's a leader in the field of vascular neurology and the heart-brain connection. He's been in his current position since 2019, and this is actually his second stint at the NIH. We also have with us today Dr. Jeff Williamson, who's a professor of internal medicine and epidemiology at Wake Forest University School of Medicine. He's also the section chief on geriatric medicine and gerontology. His main research interests are the relationships between chronic diseases such as hypertension and diabetes and brain health. He is the principal investigator of the SPRINT trial, which was a very big, significant blood pressure intervention trial, as well as the SPRINT MIND trial, which was a subset of the SPRINT trial that looked at hypertension and brain health. And I also am pleased to see him today because he and I have been working together now for a few years. The Alzheimer's Association was named by the CDC and received a grant to be the Public Health Center of Excellence on Dementia Risk Reduction, and Jeff and folks at Wake Forest are our scientific partner in that. So good to see you again today, Jeff. And our third panelist is Dr. Tony Kuo. He is the Director of Chronic Disease and Injury Prevention at the LA County Department of Public Health. He's also a professor of family medicine at the David Geffen School of Medicine at UCLA. He's worked extensively in population health, including interventions that affect specific and special populations. And he also is a CDC, involved in a CDC grant through the same program that our Center of Excellence is funded through, as LA County is a recipient of a BOLD program grant to address dementia in the community. So with that, thank you, panelists, for being with us. And let me start, Richard, with you. A lot of the people watching this webinar, Fireside Chat, have different levels of knowledge and understanding of Alzheimer's and of dementia. And a lot of the people who are going to be watching actually don't work in the field. They work in the hypertension field. So could we start with a little bit of level setting for you to just explain what is Alzheimer's, what is dementia, how are they connected, how are they different?
Yes, well, thank you, Matt, for that very kind introduction. It's really a pleasure and honor to be with you today to discuss this very important topic. So dementia is actually a general term for a group of diseases with different pathology, but sort of the same clinical manifestation. Dementia in general is a term that describes people that have memory loss, in addition to loss of one of the 7 executive functions, such as your judgment, your reasoning, and your thinking, and those other functions. And so if you have memory loss in addition to one of those other executive function losses, then you carry the diagnosis of dementia. But then there are different types of dementia. Most people have heard of Alzheimer's dementia before. Alzheimer's has been characterized because of the unique pathological findings that are there. You have beta amyloid plaques that are deposited in the brain, in addition to what are called neurofibrillary tangles. And so that pathology, when they're found together in the brain in people post-mortem, suggests that that person had Alzheimer's disease. But then there are other types of dementia, and vascular dementia is one that's very common. And vascular dementia is dementia that we consider modifiable because it's associated with the vascular disease risk factors. The number one modifiable risk factor for vascular dementia or vascular disease is uncontrolled hypertension, and that's what we're going to talk about more today. And so that sort of sets the stage in terms of our discussion today.
And just one other level setting point, because you mentioned vascular dimension. So even though people think most often Alzheimer's disease, when we talk about the risk and the connection between uncontrolled hypertension and dementia, we're talking about dementia here and not necessarily Alzheimer's disease or a particular pathology, correct?
Yes, that's correct, Matt. And that's a very important point to make, that we're talking about the general category of dementia. We'll talk a little bit more. I know that my colleague, Dr. Williamson, was the lead on the SPRINT study, and there was a sub-study of that study, SPRINT Mind, that looked at the various blood pressure levels. But when we think in terms of modifiable risks for dementia, we know that vascular disease and uncontrolled hypertension is so important. Most people actually have this mixed dementia picture where they have some Alzheimer's pathology in addition to vascular disease pathology in the brain. And so that's why this topic and this discussion is so important. I'm really excited to have this discussion today.
And I do want to turn to Jeff, because I really want to talk about the SPRINT trial because it was such a significant trial. But before we do that, Richard, is there anything else? Do you want to just in general say what we know about the connection between uncontrolled hypertension and the brain? What's the current state of the science, if you will?
Well, uncontrolled hypertension impacts the brain in multiple ways. It can lead to ischemic strokes, which is strokes due to blockage of blood vessels, and that leads to loss of brain tissue. And that's over 87% of all strokes are due to blockage of a blood vessel in the brain, and that's called ischemia. The other sort of 13% of strokes in the brain are related to hemorrhage in the brain. And so uncontrolled hypertension can lead to hemorrhaging in the brain, as well as ischemic stroke. But even more ominous than that, people that have this long period of time of uncontrolled blood pressure, it leads to damage of the blood vessels in the brain, and it leads to what we call periventricular white matter disease. And so we have these spaces in the brain called the ventricular system. And next to those spaces, we have what we call deep white matter. And that's where the nerve processes travel through the brain. And so in people that have chronic uncontrolled hypertension, they get these nonspecific white matter changes in the periventricular region. And that is associated with memory loss and dementia. And so that uncontrolled hypertension for a long period of time, that actually leads to poor brain health and puts you at risk for ischemic stroke. It puts you at risk for hemorrhagic stroke, as well as dementia.
So Jeff, let's talk SPRINT. Let's talk SPRINT and SPRINT Mind. What was SPRINT? What was SPRINT Mind? Why is everybody talking about how significant your study was?
Sure, Matthew. Well, as Richard discussed, we've known for a number of years, just if you take large groups of people who are aging in the tens of thousands, hundreds of thousands of people, we've known for a while that those people who just naturally had a blood pressure around 115 to 120 on the top number, the systolic blood pressure, that's the most important number. But those individuals had the least risk of a lot of things like stroke, heart attack, heart failure, and dementia. But what we had never done was to say, if we treat people to that level of blood pressure. Does that actually prevent more of these disabling events, heart attack, stroke, dementia? Does treating to a level of 120 prevent more of these events than treating to what used to be the guideline of 140? And so SPRINT was a study designed really by scientists in the federal government, as well as scientists outside of the government, to say we ought to test this idea. And so SPRINT enrolled about 10,000 people, and half of them were assigned to the blood pressure guideline at the time of 140, and the other half were assigned to the blood pressure guideline at the new what is now the new guideline, and that is a blood pressure of 120. And so after about 3 years of treatment, it was very clear that the people in the 120 assigned group had much less death, heart attack, stroke, heart failure. And then after and then even with that 3 years of treatment, between 3 and 5 years, those individuals assigned to the blood pressure goal of 120 also had about a 15 to 20% reduction in either early cognitive impairment, called mild cognitive impairment, or dementia. And so for the first time in history, SPRINT showed that we could actually intervene on people's lives and health in order to and then reduce the risk of developing cognitive impairment or dementia. So this gives a great hope to the field. This is the first study. I think there'll be many to come in the future, but that's essentially what SPRINT was about. People from all walks of life, all backgrounds, and I'm sure we'll talk about that in a little bit, but mainly people from age 50 to age 100 were involved in SPRINT.
And one of the things that strikes me that's significant about this, and you touched on it, about the people who had lower systolic blood pressure, can we control it? Or can we? What are the effects if we can get those with high blood pressure down to that level? And the thing to me that's really hopeful is that there are some risk factors that they say, well, once you hit the condition, controlling the condition, the evidence is much murkier about whether controlling that condition will actually then lower your risk. And so to me, what was really significant was that finding that even if you get hypertension, if you can successfully control it, you can have significant health benefits for your brain.
Yes, 2 points real quick. One is that to accomplish this, it took on average about one additional blood pressure medicine a day to do this than people were on who were controlled at 140. That's number one. Number two, even though I said that blood pressure controlled, closer to 120 millimeters of mercury on the top number was the most protective, we know that even people who might not reach that level but can get below 130, or even go from, let's say, 155 down to 140, it's very likely that they have a lot of benefit as well. Not everyone might be able to reach 120, but many people can reach 130 or can drop their blood pressure, can lower their blood pressure, I should say, and really achieve substantial benefit for their brain health.
And SPRINT's over, but SPRINT Mind is continuing. Is that correct?
Yes, we're continuing that with the help of the National Institute on Aging. NINDS helped us get this far, but NIA plus the Alzheimer's Association together are helping us continue to follow these individuals to see what are the long-term effects of blood pressure control. Only that 3 years of blood pressure control, what are the long-term effects on brain health? One thing we just recently learned was that actually with better blood pressure control, circulation to the brain improved. Many of us thought circulation to the brain would be lower if we lowered blood pressure, but it's actually higher. And we won't go into all the reasons why that's likely to be true, but this just gives a quick window into the many benefits of better blood pressure control on the brain.
And a lot of times when we talk about hypertension in the brain, we're talking about prevention, reducing the risk, which sounds like something that needs to happen when you're younger. What did you find in the study? Is it ever too late?
Yeah, I'm glad you asked that. It's always beneficial to lower your blood pressure, but in SPRINT, we found that especially in that first few years of treatment, the people that get the most benefit are the people who are the most cognitively vulnerable. So a lot of the benefit in SPRINT was actually obtained in people in their 70s and 80s. So it's just like smoking cessation. It's never too late to stop smoking, and it's never too late to better control your blood pressure. Yeah, again, middle-aged people, it's very important that they control their blood pressure. Over time, they'll probably have more benefit, but it'll take many more years to show that benefit, as opposed to that early benefit in the first 3 years of treatment, which was really emphasized in people aged 70 to 90.
Right. So Tony, I want to turn to you now. We've heard the scientists talk the science. So help me. I'm not a scientist, so help me translate all of this into real world practice. What does it mean out there in the trenches?
Yeah, no, I think Richard and Jeff really eloquently kind of highlight the science of this. And I think, as most of you know, historically, at least with brain health and Alzheimer's, we have always strived for a cure, and the messaging is around what do you do with planning and caregiving. And I think the latest on this science is really powerful in the sense that now we actually could do something with it. I mean, imagine the idea of being able to prevent or even kind of delay progression of dementia for a different number of groups. That's pretty exciting, I think, for those of us who actually practice in the field. And so I think this represents a sort of new sort of thinking process and approach that both public health and health services can actually take. I know if you were to ask most practitioners and agencies and groups that work out there, traditionally and conventionally, people understand that hypertension is connected to like chronic disease development, to cardiovascular disease, but to really connect it now to brain health, I think it's a very powerful message in and of itself.
Now, are you familiar? I understand there's a Cedar Sinai has done something on hypertension control do you know about that? Can you talk a little bit about that?
Sure. As you know, the late Ron Victor and his team from Cedar Sinai actually had conducted a very demonstrating very great efficacy using barbershop. It's the LA barbershop hypertension study, and it's to use barbershop as sort of the place or environment in which you could recruit and reach Black men who often just don't usually go to the doctors. And through that recruitment, they kind of enrolled them in this basically a comprehensive medication therapy management program led by pharmacists. And they literally have pharmacists be able to follow them over time, titrate, medication as needed. And they actually use medication as both Jeff and Richard mentioned, that are relatively inexpensive and available. And they were able to achieve really good results. And one of the things we're trying to do here now is like, how do you take a randomized control trial and then move it to maybe something that you could actually do and scale in different communities, and get in health plans to be interested in supporting it.
Yeah, I think that's really, I think that's really important. Jeff sees individual patients, and I think it's really important that we find ways to get into the community and take community level approaches to addressing this, and not just put all the pressure or put all the hope on that it will happen in the doctor's office on an individual level between patients. And I mentioned when I introduced you that LA County gets what's known as a BOLD program grant from the CDC. And I knew you got that grant to do a lot of planning and developing a strategic plan on dementia, and that grants for broader than just risk reduction, certainly broader than just hypertension. But I'm wondering if you can talk a little bit about what some of your thinking there is in terms of community level action by the public health department in LA County to address this.
Yeah, so the BOLD initiative actually turned out to be a very exciting development, because they actually gave us some resources and national roadmap and guidance on how to deal with dementia. Because we've heard for the longest time that we probably don't put enough resources into it. And so what we were able to do was we were able to take the CDC BOLD resources to help us out, but we were able to build out a coalition of almost 25 plus organization and leaders, and it includes Alzheimer's Association, your group, Matt. And what we were able to do is kind of outline potentially recommended actions. We actually ended up with 3 major focus area, and surprise, or not a surprise, was hypertension. I think everybody agreed was a very low-hanging fruit, and probably one of the things that if we could really address can really make a huge difference. And with very in some ways minimal, you don't have to put in a lot of infrastructure, because I think you just need to work with both the community and the healthcare sector to do it. One other thing that was recognized by a lot of the members of the coalition was that we do need to expand our both promoting awareness in terms of connecting hypertension to brain health, but also trying to explore all these different, including like the LA Barbershop Project, all these different strategies for basically getting into the community. So that we could actually reach both low-income population, different racial, ethnic groups, and certainly other higher, even for those who might have a family history of Alzheimer's and other dementia, probably can very much benefit.
Richard, talk to me about some of the things the NIH is doing to address this. I know of at least one very big, very exciting program, but tell me how NIH is looking to address this.
Yes, thank you for that question, Matt. And Tony, I'm really happy to hear about the BOLD initiative and all the work there in LA. I think that's great. So the mission of the NIADS is to decrease the burden of neurological disease through research. And we do that by funding solicited and unsolicited grant applications. And we also train the next generation of neuroscience investigators as well. But in addition to that, the NIADS has created something that's really novel that I'm really excited about. It's a public health campaign that's geared to the highest, the risk of people in this United States that are at highest risk of stroke and dementia, or those negative health outcomes we talked about. And that's African-American men. They have the highest rate of uncontrolled hypertension in this country. And in order to try to decrease those negative consequences of the dementia, the stroke, as well as cardiovascular disease, we worked with a public relations group contractor working with the NIADS to create a program geared towards African-American men from the ages of 28 to 45, and we consider that midlife. And so we have worked with radio stations in the Atlanta market. We're doing the same thing in DC and other areas, and this is open. We're open to do it with people across the country. The messaging is around giving knowledge, giving self-efficacy. We've developed with focus groups, messages, a video, and other materials that have been shown to increase the self-efficacy among the target population, African-American men in the demographic that I talked about, and giving them self-management tools to check their blood pressure. We know that people that monitor their blood pressure at home and between their doctor visits have better control of their blood pressure. And so we have tools for them to use, online resources, And we host periodic webinars where we can answer questions and try to get African-American men to try to check their blood pressure. And this is based upon our health equity strategic planning at the NINDS to try to better target our communications of our health findings to those groups that are at highest risk. And so we're really excited about that campaign.
Do you want to give a plug for the web address?
Yes, the web address is mindyourrisks.nih.org, and that's MINDYOURRISKS.org. So mindyourrisk.org.
Right. So Jeff, we've heard Tony and Richard talk about community, the Mind the Risk campaign. What you see, in addition to being a researcher, you see patients. What would you tell doctors? What would you tell clinicians at this point in our understanding about what they should be doing with respect to hypertension and the link to brain?
Yeah, Matthew, a couple of things. The first is, I think you heard Tony and Richard really say, we need to help people own their blood pressure more and not the health system. You know, that's really important. Management of high blood pressure is not a highly technical thing. It's something that people can do, and they can do in partnership with their doctor or their nurse or their barber, for that matter. I think one of the things is doctors need to take the mystery out of this and help people really own this, know their numbers, and as Richard said, measure blood pressure in between visits, be proactive, make a call, say, hey, I'd like, what do you think? Should I increase or not? And just not make it so expensive and complicated for people. As we said, 90% of the medicines used in Sprint, more than 90%, were generic, less than $4 a month. And so I think we need to emphasize these things to individuals. I think the second thing that doctors especially need to do, but in partnership with patients, is there's something we see in our own health system here in North Carolina, and that's what I call therapeutic inertia. A lot of people, by the way, when Richard said middle ages from 28 to 45, that was a gut punch to me. But nevertheless, but a lot of people, especially in that age group, or even older, see their physician one time a year, and their blood pressure is high, and they say, well, let me just try to work on this. And so does the doctor, and it's in the 150s already, even the 140s. And rather than wait a whole nother year and do damage to your blood vessels, we need to act on it now and then come back next year. And if you're a little bit lower than target, back off. But we have a don't do anything and let's wait. That's what that inertia means. And I've seen in chart after chart people who do that with their physicians blessing it, or the physician does it, and to I'll do anything. That is something we should not be doing as doctors or as citizens.
And would you, hypertension's been around a long time. We're just, the more recent understanding is the connection and the link between hypertension and risk for dementia. What would you, to what extent is it worth doctors with people who have hypertension talking to them about that connection to the brain? Are we at that point yet? Should they be?
Oh, absolutely. Sprint definitely proved that axiom that we've been talking about. What's good for your heart is good for your brain. Actually, I'll turn that around and say, what's good for your brain is good for your heart. We live in a time when a lot of things can be done to mitigate the effects of hypertension on heart. We don't appreciate that very often, but there's no such thing. You know this, especially Matthew, at the Alzheimer's Association. Once a person develops dementia, we don't have anything to turn that around. We don't have anything to make it a little bit better. It only gets worse. So it's even more important that people control their blood pressure for their brain health, because those changes can be prevented, but often, in fact, cannot be reversed. We know of nothing that can reverse brain damage. Nothing can really reverse heart damage, but you have a lot of other things that can be done, medicines that can be added to your medicine, to your regimen to help you function in the middle of heart damage. But it's very difficult to do that with brain damage.
So, Richard mentioned that African American men have the highest risk, highest prevalence of this. So I do want to talk about diversity and community, and specific communities here. You did a clinical trial. Clinical trials are criticized across the board for their lack of diversity. Clinical trials usually are, and I know NIH has put a lot of work into trying to change this in general. But clinical trials, there's a lot of white maleness to clinical trials. Talk to me about Sprint. Jeff, you're on mute.
Oh, thank you. I had to go through one call without that being the case. But so yes, that's a valid criticism. But I will say in Sprint, because of a lot of emphasis by the research team, the federal officers such as Richard, Sprint had almost 30% of their participants African American, almost 11% were Hispanic. And so for me, I see a diversity of patients. It's very important for me to be able to say, not just a few, but many patients like you were in this clinical trial. And so I can treat you and I can really help control your blood pressure, knowing that others like you were in this trial, a large number of people, and they've gone before you to set the example. So Sprint showed that it can be done. And we're working in many other trials now to do that as well, as Richard especially knows, and Tony for that matter.
And the findings of Sprint, Jeff, were applicable across the different racial and ethnic groups?
Yes, they were. Whenever you have something like this, you want to include enough people to say it's applicable to many different people groups. But were there enough people from North Carolina in Sprint to say it's good for people from North Carolina? No, but there was enough people, or to say it's statistically the same for people in North Carolina as it is for people in California. No, but there were enough people in North Carolina and California to say you're represented by this group. So many of the trials up to this date didn't have enough people to even say someone like you was even represented in the trial. So I hope I'm making myself clear. That was probably not as clear as I would like it to be, but.
So I want to ask Richard and Tony. Tony, you talked a little bit about barbershops, but Richard, Tony, how do we engage diverse communities? What are some ideas here? Because they're disproportionately impacted by hypertension. They're disproportionately impacted by dementia. There's probably one is probably related to the other, but how do we engage diverse communities better than we have?
You can start, Tony.
Oh yeah, okay. Well, I think at least mine is more like a local perspective. I think trying to engage communities to try to meet them kind of like where they're at, and also like making a concerted effort to, as Jeff and I think Richard have mentioned, to make a concerted effort recognizing that you do need to go into their community and understand what makes them comfortable, what are the triggers or the sort of things that would allow them to actually trying to engage providers and engage in actually taking care of knowing their numbers and taking care of their blood pressure. So I think there are a lot of things you could do. A lot of it is just a commitment to really building out that sort of community clinical linkages and more of the community efforts. Certainly, I know in LA County, we're very diverse. One of the biggest issues for us is basically languages, and so that also matters too, and also cultural norms. Being able to understand that, I think the randomized control trial and a lot of the science are there, what's sometimes missing is that we probably need a little bit more implementation research to really understand how do you actually implement some of these proven interventions in these different groups and communities.
And I agree 100% with what Tony said. Just to throw out a couple of terms, I think that it's important to build trust with the diverse communities, and you build trust by working through those trusted organizations. And so the bold initiative that Tony talked about is one, working through barbershops where people feel that trust and they feel that connection to the community. The other point that I want to mention is, as Jeff mentioned, in terms of the sprint trial, having that diversity of people, we call that a rigorous trial, and that the results are applicable to multiple groups, and it can be used. The findings can be applied to different groups of people. Unfortunately, as you mentioned, Matt, earlier, that a lot of studies don't have that degree of diversity. We think at the NIH, we talk about you have to understand sort of the prevalence of the disease in the various communities. We think about that when we're looking at studies, and we know that hypertension is very common. 1 in 3 Americans has that, and it does disproportionately impact African Americans. And so it's great. It suggests that they were able to build trust, build those connections, and develop a very rigorous trial where the results actually stand up because it's reproducible and it's applicable to multiple groups in society.
Richard said what I wanted to say way more eloquently. Much for your work. So that was great. Thank you, Richard. Hey, by the way, I want to say too that after the age of 50, more than 50% of Americans have hypertension. And by the time they're Medicare age, 2 out of every 3 have it. So there's a huge opportunity for our nation here.
So a couple of you have used the phrase "know your numbers," and we've talked about that almost self-management or self-awareness of it. But for those who have hypertension, how accessible, for those with limited means, how accessible is the ability to control hypertension?
Well,
Richard, Jeff?
I'll take a stab at that, just to say that in Sprint, we had people with a variety of, the majority of people in Sprint were on Medicare. And quite a number were a large proportion were on Medicare and Medicaid. And those individuals, again, for really less than $5 a month per medicine. So less than $15 per month. That was the average number of medicines that was required. Were able to control their blood pressure, and the control was the same among cultures and races. As it was the same. So I think it is accessible. One other point I want to make in this area too is that we've looked at this data many times, and we found that it doesn't matter what you use to get to the goal. There's a dozen medicines that are available to help treat high blood pressure. The key was getting to the goal. One medicine may work for some person and not for another, but the bottom line is that it seemed not to matter as long as the person's blood pressure was well controlled, how they got there.
Yeah, and I would just say that controlling blood pressure is something, I'm on the Federal Hypertension Control Leadership Council, which is a group of federal agencies that have been sort of discussing how can we make control of hypertension a metaphor for the state of health of the country. There's no reason why we shouldn't have everyone have control of their blood pressure. We know how to measure it. It's easily measured. There are machines that people can do that are automated to check their blood pressure. As Jeff mentioned, there are a lot of medications, and a lot of them are generic and very cheap. And most medical providers know how to control blood pressure. So you can measure it. You can measure it very easily. You can treat it with medication easily. And we know who's at risk for it. So there's really no reason that we can't tackle this. And so I think it is something that everyone can do. I just think it requires us to get people to understand the urgency of doing this. Unfortunately, a lot of people have multiple priorities that may impact them in life, and their healthcare, unfortunately, is not at the top of the list. That's something else we have to think about.
Yeah, I think it would. I want to. This comment I often tell to my patients is to say, listen, for the cost of one fast food meal a month, you can probably control your blood pressure. So, you know, we don't think in those terms, but it is really important.
In two ways, Jeff. One, they're not having the fast food meal, which will
Right.
control their blood pressure.
Right. Exactly. So
Jenny, I know you had a question.
I did, and this has been an incredible discussion, so thank you all so much. So as you all know, our roundtable is comprised of a variety of organizations, national nonprofits, medical associations, payers. What would be your key takeaway for us after this conversation? What would you like us to consider as we move forward in scaling ideas, programs, etc., when it comes to hypertension and brain health?
I'll go first, only because I have a patient waiting. So my recommendation is that we have a lot of evidence. Our bucket is full of evidence that controlling blood pressure works very well for so many things, the brain included now for dementia. I think the partners that you listed there, Jenny, we need their help in the healthcare system to develop better ways to reach more people to get this done. That's so multiple avenues for pragmatic approaches to controlling blood pressure in the community and the healthcare system. I think we haven't begun to look at how to do that. If you look at transportation, has many different. I'm looking outside my window. There are 100 different vehicles that have come by in the last 20 minutes. We don't have 100 different vehicles to control blood pressure, but we need to do that and tailor it to people's choices. And I think we can get it done a lot better.
And my response goes along with Jeff's as well. As a representative of the NIH, we really need more investigators to think of those interventions that are known to work, like the BOLD initiative that Tony talked about, and using implementation science to export and implement these interventions throughout the country and throughout the world as well. I mean, this is a major problem in the world, but definitely here in the United States as well. So we fund research. So we need really good implementation studies and new interventions if they're out there to tackle this problem.
Yeah, and then I think for me, I echo both Richard and Jeff's comments. I think for me, it's about recognizing that the science is there, making that connection that hypertension and brain health should be in the same conversation, and then truly exploring and finding ways in which we could actually take what's effective and actually be able to disseminate it and use it in the community context.
And this has been a very fascinating conversation. I think I got through about half of what I would have loved to have talked to you guys about. We could easily, at least I could go on for another 45 minutes. But I want to thank each of you. Jenny, I'll turn it back to you to close, but thank you for the opportunity to have this conversation, and I look forward to having more conversations about the connection between hypertension and brain health, and including, I'll leave you with this thought about whether we should stop it out in the real world using the term hypertension and just talk about high blood pressure instead of the medical term. But I'll leave that as a thought to ponder for the future conversation we have. Thank you, Jenny. Thank you, panelists.
Thank you.
Thank you all. This has been an incredible conversation. And as Matthew mentioned, I hope this is the start of a long-term conversation. I would welcome you all back to potentially present at our annual summit later this year. This is such an incredibly important conversation. We have some takeaways. Matthew and I will be in person together next month for our board and